Tēnā koutou katoa. Before I start, I'd just like to acknowledge the tangata whenua of this land that we're on. And since it's Māori Language Week, I'd just like to introduce myself in Māori. So, ko manaia te maunga, ko rua kakatawa, ko Ngāti Pākehā te iwi, ko Kyle Eggleton take ingoa. So, I'm a GP from Northland. I work for a iwi health provider. And a couple of years ago, I was working as the clinical director for Northland in primary care. And at that time, a number of the DHBs around the country were looking at something called the Global Trigger Tool, which I hadn't heard about. And I heard a talk from our local chief medical officer about the Global Trigger Tool. And essentially what the Global Trigger Tool was looking at hospital kind of data set and looking to see what adverse events were occurring there. And I thought, well, why don't we do this in primary care? And I found out about Scotland, how Scotland was using the trigger tool in primary care. And I thought, well, maybe we can adapt this to the New Zealand scenario situation. So what I'm going to talk about today is just a little about the work that we did in Northland on developing a primary care trigger tool. And then I'm going to talk a lot about the nuts and bolts of how to do it. And then maybe in our discussion we can talk about what's actually like, and I'd be interested to hear kind of from Bevan again what the issues were. So trigger tools, you've heard that trigger tools are trying to identify adverse events, but they really started off in the anaesthetic literature about 20 years ago. And they're really a set of flags or occurrences or prompts which might alert someone who's looking at a medical record that there's some sort of harm that might have occurred within the record. And really the intention is to alert healthcare staff to potentially risky situations and hopefully to kind of make some changes and do some quality improvement measures. So, it's not normally a smoking gun, sometimes it is. It's sometimes quite hard to actually kind of think, you know, what is a trigger? And the way that I talk about it is really to think about triggers as being like the tree. You know, you're in the desert. Imagine you're in the desert, and you're going to get dehydrated. You're looking for water. Now, you're not going to find water in the desert just by stumbling across a pond. You might, but you'd be pretty lucky. Instead, you're more likely to find a palm tree in the desert, indicating an oasis. Now, water is the harm, and the palm tree is a trigger. So what you're looking for is that palm tree that's standing out in the clinical record. Now, trigger tools, as you've heard from Anne, have been used in Scotland for a number of years. There haven't been that many studies done on it. Matter of fact, probably I could only find 2 decent studies on primary care trigger tools at the time that I was looking at it. And there are some issues with trigger tools. Specifically around the issue around sensitivity and specificity of trigger tools and its feasibility. It's estimated from one study looked at that you could review about 20 records in a 2-hour session using about 8 to 12 triggers. And I guess the reason that we're really interested in trigger tools is trying to identify those real bad things that happen. Hopefully we don't have this happen to us very often in primary care, but it does. Earlier today we heard about the kind of like the rates of harm in primary care, and we don't really know exactly how much harm does occur. There's been very few studies done in primary care. Most studies are really relying on self-report. It's estimated that the rate of harm is probably somewhere between about 10% to 15% of consultations end up in harm. And in contrast, the rate of harm in secondary care is a little bit higher, probably about 2 times this. We've also heard from Catherine today that most harm seems to result from medication. So there's some unknown stuff about harm in primary care, and Sue Dovey, who's sitting down here, is doing some work at the moment looking at the epidemiology of harm in primary care by doing a large retrospective case review of 10,000 records. And if you're at the conference later on, Sharon Leach is going to talk a little bit about some of the issues that we've had so far in looking at accessing patient records. So just a little outline of what I'm going to be talking about. I'm going to talk first on my study that I did in primary care trigger tools, and then I'm going to talk about the practical applications for the trigger tools, and then some tips and tricks. So, what did we do? Well, we started off by looking at the literature and trying to think about what sort of triggers there are. Now, we came up with a list of 36 triggers based on some of the studies that we looked at, and also some consensus work that we'd done between our team of researchers. And I'll talk a little about the trouble of identifying 36 triggers within a record. We decided that we'd look at 170 patients in 1 year of data, and that was based on some power calculations that we did. And we had two review teams. One consisted of a GP and a practice nurse, and the other consisted of a GP and a pharmacist, acknowledging that medications is one of the highest or leading causes of harm. And then every so often we did reconciliation between the teams just to try and reach some sort of agreement. So our patients, well, we included young people, included children. Most studies haven't included children, but harm does occur in children. And we had 50% of our patients being Māori, which is, I did that on purpose, just trying to identify if there's any difference in harm occurring between Māori and non-Māori. And we had slightly more females than males in our cohort. Now, who's ever done a review of the patient record? Hold up if you've actually done a review of. Yep. What was it like? Tedious, laborious, very boring. Imagine, I'm doing the study with Sue. We're looking at 10,000 records. Imagine how much fun that is. But it is a very laborious process. And the idea of trigger tools is to make it less laborious. And there's some tricks and tips that we can use to make it less laborious. So we had 40,000 days of follow-up in our cohort, and this consisted of about 637 consultations with a typical Northland GP. Sorry, Lance. She didn't actually use Lance's practice. And during our record review, we found 1,033 potential triggers. Remembering we're using 36 triggers. The idea being we're trying to narrow down the triggers to a tool that was actually quite feasible. And from those triggers, we picked up 44 harms. Some of those harms were picked up by a couple of different triggers. And we had one harm that wasn't picked up by a trigger. So what we did, we went through the record looking for triggers within the record. And then if there was a trigger, we'd drill down further into the record to try and find out if there was any harm that was there. And then independently, we went through the record kind of like consultation by consultation to see if there was any harm. The idea being we wanted to really work out the sensitivity and specificity of using trigger tools. So, what kind of harm did we pick up? Well, we used something called the WHO National Coordinating Council for Medication Error Reporting and Prevention categories. And this ranged from E, which was kind of harm which was temporary but required intervention, up to category I. So what do you think category E mostly was? Medication? Yep. It was mostly medication, so minor sorts of adverse events, things that you sometimes might expect when you're prescribing medication in an appropriate manner. We had one death, and just to tell you about that death, that was a patient who was in hospital, was admitted to hospital with heart failure, came from a rest home, was treated in hospital with heart failure medication, and then was sent back out into the rest home, and the GP didn't prescribe the heart failure medications that had been initiated in hospital, and the patient died about 3 days later of fulminant heart failure. And that wasn't really picked up in the record at all. The GP wasn't really, when you had a look at the record, didn't really kind of acknowledge the fact that there was an error there. So, the outcomes of the study, well, we found that 7% of consultations in our cohort resulted in harm. And there was little difference between males and females, and little difference between Māori and non-Māori. So, really the idea was to try and make this a workable tool because trigger tools, as I said, potentially can be laborious. So we wanted to make this a really useful tool. So we went through a process of refining the triggers, cutting out those 36 and making it a more manageable number. And we excluded triggers with very low specificity. And this ended up reducing the triggers down to about 7, which we called the refined primary care trigger tool. So if you've been paying attention, you would have seen Bevan's slide with some of those triggers. Can anyone remember what some of those triggers were? Sorry? Yep, we had EGFR less than 35. Yes, yep. So we had consultations within a week with a prescriber. Yes, so we used discharge from ED or from accident medical centre. We didn't actually find that one particularly useful, so we didn't use that. Once again, we didn't find that useful either. I know that Bevan's group has used that, but we found that had very low specificity, so excluded it. Age, no, we didn't use age. The other thing, remember about medication? So it was about if there was an adverse event and if medication had been stopped or had been reduced. So that's our list there, and included death as well. And the other really important one, which was talked about this morning, was about greater than or equal to 6 medications that were prescribed. So any idea which one of those was the most useful? Thinking around medication, I guess. Yep, it was actually, it wasn't actually. It was, and you'd think that it would be adverse drug reactions, wouldn't you? But we found that GPs actually weren't that good at documenting adverse drug reactions in the record. Maybe there's a quality improvement thing that could be done there. What we actually found was that if the most sensitive thing was cessation or reduction of medication seemed to be the trigger that alerted us to some harm occurring. So what we're doing with triggers is that we're trying, this is a retrospective thing. So if you see in the record that a medication has been stopped, that might alert you to dig further into the record. Okay, so this is not the cause of harm, this is the alert. So that's about a retrospective case review. Okay? Does that make sense? Yeah. So if you use this tool, then the odds ratio of harm occurring if you identify one trigger is 3.4, and this gives a moderate sensitivity of 81% and a moderate specificity of 51%. So it's not too bad as a tool. So I'm going to talk about how you can actually use this in your practice. And there's a couple of ways of doing it, a couple of ways of using trigger tools. I'm going to talk about the obvious way, and I'm going to talk about a way which I use at the moment. So the obvious way of using trigger tools is reviewing your own practice. And the intention is really to look at occurrences of harm and trying to examine those occurrences of harm and seeing if there's a pattern that occurs and seeing if you can actually make some quality improvement changes in your practice. It's not going to give you a quantifiable measure of harm in your practice, unless you did every single patient, which, good on you if you did that. So it's really looking for some things that you can change. The other thing that I found, which didn't really come through, didn't come through all these numbers, was the thing that I really found was about the patient experience and the patient story. I found it was really powerful as I went through the record. I found some things that kind of made me shudder, really, about some things that didn't actually result in harm, but were a very poor patient experience. So many of those things were relating to medication lists, so the medication lists were often inaccurate, and in the larger practice that I was looking at, we had multiple doctors that were involved and no one was really taking any responsibility for the medication list. And so, heaven help you if you're a locum in there trying to work out what medications the person was on. It was diabolical often. often there was very inaccurate repeat prescribing, and I saw one poor chap, he kept on ringing up for his medications and got given something, but something was missed off, and he rang back again, and it was missed, another thing was missed off, and this poor chap rang up 4 times to get his medication, and he got charged 4 times. So, you know, there's this patient experience stuff that really comes through when you're looking at the record, which I think is really, really powerful. The other thing which I use it for at the moment is I'm using it in a mentoring type role. So, you know, I often have some GP colleagues which are struggling or there's some concern raised about them, and I undertake some mentoring with them. And I use this tool to have a look at their record and just give me a handle on what's going on. In 2 of the last cases that I've looked at, 2 of my GP colleagues had about 60% of the consultations resulting in some form of harm. And from that, we could do some work to try and reduce harm and put in place some systems for them. So I really see that this tool can be used not only for your own practice, but in a collaborative kind of mentoring type role as well. And as I said, this is not really a quantifiable thing. I would hate to see this being used as a target or some sort of measure. Okay, so I'm going to talk a little about, or maybe I'll get you guys to talk about how you would use trigger tools in your own practice. So, you know, we want this to be something that's easily done. How would we look at, I'll use an easy one, how would you look at adverse drug reactions? Simplest thing. Yeah, if it's recorded in the notes, so I use medtech. Anyone who doesn't use medtech, just so I know? Yeah, okay, about 10%. So in medtech, there's just a adverse or medication alert thing there. What I do is I quickly flick on that if I'm doing a review and see if there's any medication alerts that have popped up, and then I just jump to that particular place in the record, drill down, and see if there's any harm. The other easy one to look at, if you have a look at those there, number of medications is relatively easy. Consultations is relatively easy, and I'll talk about how to do that in a minute. Death, that's hopefully pretty straightforward. So some of them are a little bit more tricky, and I will just go. My apologies to those who don't use medtech. I'm going to use medtech as an example about how you use trigger tools in medtech. So, what we're going to look at first is what I do and how you look at medications. So the first thing I do is I get a list of just the long-term medications, and I want to print that off. In case you don't know how to do that, you know that medications, the long-term ones are written in blue. And to print off a list, what you do is there's what I call the rainbow button. I don't know if it's got another name. Does anyone know if it's got an official name, apart from the rainbow button? The filter button, okay. The filter button, the rainbow button. So I click on the filter button and I click long-term only, and then I just get a list of long-term medications, and I click this print button and I just print it off. And I use that so I can just scroll through the record. And the next thing I want to do is I want to find out if there's been a reduction in medication. Now, what you could do is you could scroll through the notes and look at every consultation to try and see if medication has been reduced. But it's kind of defeating the purpose of a trigger tool, really, because effectively you're doing a whole kind of review of the record. So if we're using trigger tools, we want this to be fast and efficient. So what I do next is I go back to the rainbow button and I click on Show All. Now, the default in medtech is to have most recent only. And what most recent only does is it misses out all the instances of prescribing. So if you want to see if medication has been changed or missed out or reduced, you need to click on Show All. And what that does is it gives every medication that's been prescribed at any one time. And I use my printed off list and I quickly scroll down that entire list of medications to see if there's any change between the long-term stuff and what was actually prescribed at that date. And if there was something that was changed, then I jump through to the record and look at that particular date and why that had occurred. Yes, you probably should include inactive as well, although that's kind of like a little bit dodgy to click something that was inactive. And I did do that on a review of a doctor. I clicked on inactive, and it showed that he had prescribed a medication, which was, now what was the story? He was supposed to prescribe I can never pronounce it properly, bisoprolol, but had prescribed something else that sounded very similar, and the person got an adverse event from it, and he tried to cover his tracks by clicking inactive in the record. So that's how I look at medications. And the other thing I do is I want to see if the person's been in to see me or another provider 2 times in a week. And what I do is I click on the appointments tab and I just scroll down, and it's easy enough to see whether someone's been 2 times a week to see me. And if they have, I have to flick through to the record to see what went on there. The other thing I do is I print it off because I need that for the next part. And that is really looking to see if someone's been into ED or hospital or an A&M. So I want to have the list of when I've seen them and compare that to when they came in or when they were discharged from hospital. So the way to do that is in MedTech, you click on the filter button again, the rainbow button, and there will normally be some sort of consistent way in which the electronic record comes out to you in your inbox. And in Northland, discharge letters are, funny enough, called Discharge. So I type in that little box there saying containing text, I type in Discharge, and it filters the inbox record. So all I see is just all the discharge summaries, and I compare that to my list of when I saw them, and if I've seen them within the same time frame, then I quickly flick through to the record. So that's what I do for trigger tools, and doing it this way I've found that it doesn't take too long to quickly look through a record. I acknowledge I'm going to be missing some occurrences of harm, but the idea of trigger tools is to make this a reflective process and to kind of make it a practical process as well. You don't want this to be a laborious thing. You want this to be something that you can really reflect on. So what I really found as a result of all this was that the rates of harm in our little study was comparable to the literature. And once again, we found that medication was the main cause of harm, and the harm was predominantly minor. I found that there were many errors in general practice, but they were not associated with harm, and that really impacted on the patient experience. And obviously there was a need for a larger epidemiological study looking at harm in primary care, which is the next step. So that's my little talk.
Well done.
Okay.
Kyle.